Okay, Gunjan, let's start.
Okay, that's good. Okay, so good evening, everybody. So today we'll be starting this PG program. I am Dr. Gunjan Jha, National Treasurer of Spice Root India Movement. Today we will be encountering a lot of esteemed personalities of family physicians across the country. We will be starting with the referral program by Dr. Nitish Garg. He is the representative lead from Uttar Pradesh. And we'll be starting.
Yeah, hi, good evening. Myself, Dr. Nitish Garg. I hope you can hear me, and it's a nice evening. It's good to see almost 60 plus participants, and many more will be joining us soon. So today we have gathered together for our first ever PG orientation session, and it's a big thing for Spice Root India movement, and we'll be getting to know more about what is Spice Root India movement and what is AFPI, that is Association of Family Physicians of India, what all work we are doing, and a very big congratulations to all of you guys who have joined this branch of family medicine, and it'll be a roller coaster ride for the next 3 years, but I hope you will enjoy this ride, and we will be there with you together in this ride. If you have any problems during the next 3 years and plus also in the future, so we will be there to help you, guide you, support you, anything which we can do in our capacity, so that your ride becomes a bit smoother. Also, I think now most of you have recently joined, so it'll be difficult. It might have been difficult for you to understand what is family medicine and how do we think of a future of family medicine. So all these things will be discussed here, and I hope that you will enjoy this session. And if you have any queries, keep them in the end, so that we can answer them together. Also, my humble request to join AFPI, and because support of all of you will make our association and bonding much more stronger, and we'll be having a good time. So over to you, Gunjan.
Thank you, sir. So now we will be talking to the AFPI National President, immediate past Bonta South Asia President, and editor of the Journal for Family Medicine and Preventive Care. Let's listen from him that what is the enthusiasm that has motivated him for pursuing a career in medicine and how it is growing in the country. Raman sir, now we'll be listening to you.
Thank you, Dr. Gunjan. Can you share my slides, please?
Sure, sir.
And I welcome all participants to this meeting. This is my brief introduction. I've already been introduced, so we can go to the next slide. I'm also convener of Specialist Board, National Board of Examinations. I wear many hats, also National President of Academy of Family Physicians of India. We have a Journal of Family Medicine and Primary Care. And I was also affiliated with BONCA, which is World Organization of Family Doctors. Next slide, please. So I've been asked to introduce family medicine, and it is a medical specialty of its own. It is recognized by Medical Council of India since long. The first mention of recognition of DNB qualifications comes in the 1984 Gazette notification of Medical Council of India amendment, through which National Board of Examination was created. So you can assume that it was recognized long back as a PG qualification in 1983. And since then, we were having full-time residency training programs in India. And several reforms, waves of reforms have undergone. Now there is a renewed push from the government to rejuvenate the residency training in family medicine. And apart from DNB, there are diploma programs which are being offered from this year itself. So we have seen many seats across India in diploma have started, and many DNB programs we see have been reinitiated because there was a long gap of accreditation process of 3 years almost. It is an academic discipline which is different from community medicine, general medicine, forensic medicine. It is family medicine, and how it is different, I'll discuss a little more. And but legally, it is a different specialty, and you should never get confused in your mind that it is part of community medicine or general medicine. It is a different philosophy of care, because it's normally we are exposed to the hospital-based care, but philosophy of care in terms of the context of community, in terms of care for the whole body, whole person, and it is a vocation. Every discipline specialty has a vocation to practice, and this is a vocational practice in family medicine. In many parts of the world, it is known as general practice, especially the Commonwealth countries, but largely America and India, it is known as family practice, family medicine. And it is an important service interface because 95% of the patients or community-based morbidity can be addressed through the discipline of family medicine, all age groups, all organ systems, and all genders. Next slide. So these are the principles of family medicine. Normally, we are not introduced family medicine as a discipline during our MBBS training. So we are not aware of this discipline, and many times people confuse it as family planning. Sometimes they take it as a extended rotation internship, but it is a distinct specialty in itself. And there are principles of family practice. This is a famous paper by I.R. McQueen, and I'll not go into details of these practices, but I'll give you some insight of the foundational. Next slide, please. So this is, you can say, father of academic family medicine. Dr. Ivan McQueen is a Canadian family physician, and he has written a textbook of family medicine. And you should all, before going into residencies, start getting yourself introduced with family practice from this textbook, or reading about this great man, great person, great teacher of family medicine who initiated the concept of the 9 principles of family medicine. Next slide. So these are the main principles which are have been enumerated by in the 9 principles. It is the patient's context, person, not the problem. It is not from the disease perspective, but who is suffering is important. And patient context is very important because what family, socioeconomic background, age group, gender, the same problem, same diseases may have different implications, different presentations, and we have to see from the patient person-centered approach. And there has to be a preventive attitude. Prevention, we often read in the context of community medicine, PSM, but here prevention means clinical practice of clinical prevention, health and wellness. Simple things like smoking cessation, alcohol dependence management, weight management, and other lifestyle changes, which can be objectively implemented in your day-to-day practice. And we also do population health, public health. We utilize the community-based resources to the maximum, and we integrate life with work. Occupational health is also very, very important aspect of family practice, and subjective aspects of medicine, because as I discussed, same pain may be experienced differently by different persons. So the treatment or the approach to management may vary, and resource management is also an important aspect of family practice. Next slide. So this is the Academy of Family Physicians of India logo, and you see the 9 rings which represent the 9 principles of family practice. And we all welcome you all to this organization, which has pan-India presence, all states, north to south, east to west. And these are the foundational concepts. The first, contact care. So whenever there is someone who is having some experience of any symptom, the first person is family practice, irrespective of the discipline, syndrome, symptom, specialty. The first person normally, when they have headache, stomach pain, chest pain, or any symptom, is the first person is a family physician, family practitioner. And the concept which is very, very important, pertinent to family practice distinction, is whole person care. Normally, we are introduced during our MBBS curriculum is the fragmented discipline-wise, body-wise, organ-wise care, which is fragmented, divided into different disciplines. But who is the doctor or physician of whole doctor? So this aspect of whole person care, person-centered care, I already discussed that every person has a unique requirement. For example, in COVID, what day, which day, age, what symptoms, same disease having different manifestations. So the person-centered care is important. Every person requires a tailor-made treatment. Family-centered care because we live in our families and every family has different kitchen food habits, customs, rituals, which make our lifestyle different. And this may impact the care of the person. And community oriented, largely out of hospital care is taken care by family practice. Life cycle care means from pediatric to geriatric, from birth to end of life care. Every aspect of life is life cycle care, and this is also one of the foundational concepts of family medicine practice. Next. Then ecology of care is basically, it is a famous research published in New England Journal of Medicine, where for even any given population, for any month, around 750 people would experience some kind of illness or sickness. Out of them, 250 will visit a physician or a healthcare provider. Only 9 require admission to a tertiary care center, and 1 goes to a medical college teaching hospital. So you see the morbidity in community is largest, which is around 250 times of what we see in medical college hospital. So family practice, family medicine deals with the 250 morbidity, which is 200, 250 times of what you see at a tertiary care or a medical college hospital. Continuative care is like same patient visits you for different problems, during their childhood, adulthood, elderly, old age, same person coming with infectious diseases, non-communicable diseases, diabetes, different problems, different times, but they come to the same doctor and they have a continuity in their care. Comprehensive care is about irrespective of the symptom, syndrome, or etiology, the provider is capable of giving care, be it a skin problem, mental health problem, locomotor problem, vision problem, eye problem, dental issues, oral health issues, sexual health issues. Everything is provided by one provider in the community setting. And this is scientifically proven in practice. I'm sitting right now in clinic. And this is comprehensive care because, you do not send for small problems to other referrals. Epidemiology of illness is like, diseases evolve during their course of illness. So somebody having headache may not be a neurological tumor or dental health issue in the first instance itself. So when it comes to you, it is a symptom, and over a period of time during course of illness, it evolves into different diagnoses. So when it comes to you, diagnosis is not clear. Mostly treatment is empirical, and this is also complexity of family practice. Family physician is a generalist. So the term of generalism is very important. We always know from basic to specialist to super specialist, but generalism is very, very important concept in terms of whole person care, and especially when you work in community setting. So journalism is very, very important component of this discipline. Next. And this one is perhaps the last slide. This is also managing complexity. So it is not simple to manage the whole person. One person may be having mental health issues, for example, elderly person, neurological issues, diabetes, chronic kidney disease issue, multiple issues, and they may be living in a different socioeconomic situation in a different family. So every person is unique, and this all makes the situation complex to handle. And within this, we have to navigate the treatment management plan. So this is managing complexity. Care of multimorbidity, I already discussed, multi-system, multi-organ problems in same person. So we have to take care of all. Long-term care is for care for non-communicable diseases like thyroid, hypertension, diabetes, and these require lifelong diseases where one has to provide treatment through early stage screening to the complexity. So this is long-term care. Clinical prevention already discussed. Weight management, health and wellness, diet, physical activity, provision, all these things. And home care is very, very important component emerging again back and this is to be provided by family physician in terms of community setting. So these are the foundational concepts which are important, pertinent for all of you to know, which make you a distinct physician from anybody else who is a hospitalist or working in other discipline. The hypertension, bronchial asthma, diabetes remains same, but your approach to treatment is different because you're based in community. Mostly you are taking care of multiple other things at the same time. And fundamentally the treatment, if you talk in terms of what treatment is provided, it is same because it is standard treatment guidelines for any specialty. So treatment by provider is not different. It is different. It may differ from the person to person, person-centered care. So be it an MBBS doctor, an MD physician, or a family physician, or a DM endocrine, that treatment of diabetes remains same. So we have to be updated and keep our knowledge abreast at the best of the current level, and we provide best of the care. So this is all about the fundamental foundational concepts of family practice, and this is what AFPI about. And we are here to help you, guide you regarding any of our future career disciplinary problems. We are a distinct specialty through journal. Next slide. We have test books, and we also have international conference. This one conference is coming in next year. It will be in Australia, Wonka. We had a national conference in Hyderabad. There are many state level conferences coming up. Next up is in Mysuru, Karnataka, and then in Kerala, also in Pune, Maharashtra. So you are all welcome to join and participate in these activities, international, regional, and state level. So hope this engagement with this discipline as a career choice is fruitful and successful to all of you. Thank you very much.
Thank you for sharing what's a content, sir, and for taking out time for the new residents.
Okay, thank you.
Now we will be listening to another very eminent personality. AFPI, the Academy of Family Physicians of India, was a brainchild, and Vandana was also involved when this was being received. She is National Secretary of AFPI, and I will be listening to.
Thank you, Gunjan. Can you hear me? Thank you, Gunjan. Thank you for the nice introduction. And I have given you my slide. Kindly share it on the screen, please. And good evening, everyone. Welcome aboard. And yes, it is very nice addressing you all. AFPI, I have been asked to discuss about AFPI, and it is an honor, in fact, to introduce AFPI to everyone because it is very close to our hearts. We have met the president and the national secretary, founder national secretary, and yes, a founding member of AFPI. Gunjan, kindly start the slides, please.
Is it visible?
No, it is not visible.
Not visible.
Now is it visible?
Yes, now.
So, AFPI is Academy of Family Physicians of India. As the name suggests, it is an academic body. It is a non-profitable organization. The purpose and sole purpose of this organization is academics only, and bringing all the doctors who has a vision of practicing family medicine or being a family doctor to the community is what AFPI is about. It is a national body, but yes, it has an international connection also. And it was when we had joined family medicine, we were individuals. So the vision was to bring everybody under the same umbrella, to have the same vision and to give what the community required, a good family doctor. Next slide, please. So about the logo, Dr. Raman has already told about the 9 dots and the 9 principles of family medicine. And it was found, the AFPI was formed on 27th of September in 2010. And it was formed in my clinic only. We 9 members, we signed the paper there itself and formed AFPI with the vision of, kindly mute your mics, please. So with the vision of bringing the concept of family doctor, which was dying in India, and the Indian community required family doctors. Everybody cannot go to the secondary and tertiary centers. So now we are almost 14 members. We is the organizing body now, and yes, we started with 100 faces, then 200 faces, then 300 faces. Slowly and gradually, yes, people joined in, and everybody is into teaching, studying, learning, and bringing knowledge, skills, and education to each other. And yes, it has been a great journey. Past 12 years has been very beautiful, though it has been a struggling phase for family medicine in India. But gradually, slowly, we are together, we are reaching somewhere. Next slide, please. These are all stalwarts of family medicine in India. And as Dr. Raman has said, we have spread all over India now, from north to south, from east to west. Everywhere the AFPI members are there. And there is a channel where you can communicate anywhere. You will get a AFPI member there practicing. And yes, that patient can be taken care there itself. So we have a good networking. If you join the AFPI, you will have family physician and member all over India where you can connect your patient to. Next slide, please. So yes, as I have said, AFPI is almost all over in India, and almost 20 state chapters we have formed up till now. And these are the presidents of different states. So next slide, please. These are the presidents of different state chapters: Odisha, then Tripura, Assam. Keep changing the slide, Gunjan, please. Next slide. But Dr. Sumana Datta, she is the national executive member also, is the president of Calcutta. Dr. Sarmishta Purohit from Rajasthan, Dr. Kiran Mai from Telangana. And mind you, South state chapters are very much active. Telangana, Tamil Nadu, Kerala, Andhra. These all states is Karnataka. These state chapters have been very, very active, and whoever are on screen have been long connected to AFP, are very active academic people, and you can connect to these people. They will always be. Dr. Kishore Malwani, a very senior member, is the occupational specialist. Dr. Piyush Jain is in UP Agra and in the government services and giving so much to FPI. So these all, next slide please, these are all the senior members of AFPI. Dr. Gohar Bagai from Jammu Kashmir, Dr. Raghavin from Andhra Pradesh. These are all senior members, and you can all connect to these state chapters where different academic, at the state level, different academic functions and organizations are working on. As far as the national executive, these are the 9 members of the our national executive. Next slide, please. Yes, these are the members. 1 or 2 members are missing here. Dr. Sumana Datta. So this is me, Dr. Raman, Dr. Mohan Kuben, who is the president-elect, and Dr. Jekin, she's from CMC Vellore, Dr. Piyush Jain from Agra, Dr. Srinivas, he's the past president of Telangana state chapter, Dr. Reshmi, she is an educationist and the past president of Kerala chapter. This is the national executive. Next slide, please. So why you have to join AFPI is because AFPI has different state branches, and everybody, the academic functions are going on, and there are special interest groups also attached to AFPI. Dr. Devashish Sani is running the private practitioner special interest group. There is a CPD activity, continuous educational program online, which is led by Dr. Kamlesh Bhargav and Dr. Rashni Jha Ganguly. Every month, once an educational session is going on. Then there is a rural chapter, which is run by Dr. Pratyush. Then the research chapter, which is being run by Dr. Ramakrishna Prasad. And there is a spice route activity, which is a young doctor movement. Spice route, post MBBS 5 years, if you are there, then 5 years, then you are a spice route member. And the young doctor movement is internationally active movement, and the AFPI spice route activity is also there in India. Next slide, please. And these are the different uh, groups of AFPI working parties where you can have your special interest and you can work in those lines, like women's health, geriatrics, occupational health, palliative care, urgent care. These are the different branches where you can, if you can enhance your skills and practice accordingly. If you want to run your clinic, that will be the best option, surely. But if you want to specialize into a branch, these are the different branches where a family practitioner can, yes, specialize in and can enhance their skills, and they can excel in these fields. Where people are lacking, India is lacking these practitioners. And yes, India in our community needs them. Next slide, please. These are the different awards. We have our national and state level conferences, and during our national conferences, which is till now is being held every 2 years. During COVID also, only we had to skip 1 year. Otherwise, every 2 years we have been running successfully these national conferences where, mind you, there has been no, sponsorship by the any pharmaceutical companies or anybody. It has been by the registrations or the support of the academic bodies that we have been having our national conferences and state level conferences. And we have different awards: best chapter, best young doctor, even best thesis award also. So if you are writing your thesis, you can send it to us, and these theses can be selected for the best thesis award during the next sixth conference, which is going to be held next year, next in 2023. So next FMPC is 24. So next FMPC will be being organized by the UP chapter, and it is probably being maybe held in Rishikesh, AIMS. But yes, it's still under process. Next slide, please. As Dr. Raman has said, there are multiple state conferences are being held. So recently, just we had the Tamil Nadu chapter state conference. Now we are going to have Karnataka on December 10th and 11th in Mysore. Then the Kerala state conference is being held in January. Then the Maharashtra state conference is being held in February. It was on 8th Jan. Now it has been shifted to 5th February. So there have been lots of learning opportunities during these state conferences and unique topics, which you will not hear anywhere except for the AFPI chapters and conferences. And Wonka, there he has, Dr. Raman has already mentioned. So there is a rural party also, which is Versa, and Young Doctor Movement internationally, and is by Wonka, and you get the institutional membership by joining the AFPI membership. Next slide, please. So we have been celebrating the World Family Doctors Day on 19th May, but now this year onwards, we have announced 27th September as AFPI Foundation Day, which is the National Family Medicine Day also. So yes, it will be your day from next year onwards. Start working on it, join hands together so that India will recognize that the value of family practice and family medicine in India. Next slide, please. Family doctors always there to care. And website and social media. Yes, we are working on it. The website is there. And as far as the membership is concerned, you can log into AFPI website, where the membership is, the charges currently is 7,500, but for the PGs, students and other young doctors, the PG students, the membership at current is 5,500. And you can buy on the pay online on the account number, or you can do Paytm on a certain number. The details will be shared to you, or you can go to the website and the link is there. So we are all working for the future family medicine, and the project India is the Safe Family with Doctors. So yes, we need to join together, come under one umbrella, and yes, revive this concept of family medicine. Spice Route is Young Doctor Movement. These are the three. This is the president, the secretary, and the coordinator. Three. We have exchange programs also where the students from outside come here, and from India they go outside. Then we have journals, and then conferences where you can present your posters, your thesis, your abstracts, your studies. We have had this World Rural Conference was held by in April 2018, and we were the first to get this conference in India. And AFPI was very proud of doing it, and everybody recognized the work of AFPI during this conference. Next slide, please. The first, the next slide. The first, our national conference is called FMPC. The first was held in 2013, the second in 2015, both in Delhi. Then we had in Kochi in 17. Then we had in Bangalore. And then recently we had it in Hyderabad this year, and next to next year the same will be held in probably Rishikesh. Next slide, please. Next slide. Yes, these are all FMPCs and the conference we had. So yes, join AFPI. Why? Because you have to surround yourself with those on the same mission as we all are. It will boost your confidence and self-esteem. We will offer you assistance and guidance wherever you will need. We will support you unconditionally. We will push you wherever you will stop. You will stop. You have doubts. And yes, we all speak a common language. So join us, join FPI. Thank you so much.
Thank you, ma'am. And now we'll be moving to our next session, which is about future of family physicians and leaders. And who else to talk about leadership than our Colonel Dr. who is spearheading this campaign not only in southern states but across India, and is such a big motivation for all of us. Sir, I cannot unmute you.
Yes. Audible? Am I audible?
Yes, sir.
Yes, sir, we can hear you clear.
Yes. Okay. Thank you, Gunjan, for that introduction. Firstly, good evening to all of you. And please accept congratulations and my compliments for choosing family medicine as your career option. It's not an easy decision to make. So my compliments and I congratulate all of you. I have probably 5 minutes to speak on leadership. I think we are running short of time, and there are a lot of important topics lined up. So I will try to stick to my timing. Firstly, since you have joined family medicine, I think you've already shown the intent to be a leader. So I don't have to speak much about leadership now, I think. Many of you friends would have joined family medicine, would have taken up family medicine as a choice, but some of you probably would have landed by chance. But please don't repent. I'm telling you with conviction that at the end of it all, you will have no regrets. Many of us were in a similar scenario. In fact, we were in a totally different scenario. We were in a worse scenario where we didn't know what we are doing, and we didn't have the focus, and we didn't know what lies ahead after the PG. But still, after even 10, 12 years of completing post-graduation, today I can say that most of us have done well, both professionally as well as financially, and we have no regrets. So I'm pretty certain that you will not have any regrets for choosing family medicine. One of the attributes of family medicine is to be a leader. Leadership, one of the main attributes of, with Dr. Raman has already brought out in his speech, is to be a leader. Whatever you do after PG, whether most of you, I presume that you would have joined this course to set up your own practice, you knowing fully well that at the end of the course, you will be equipped to function independently as a family practitioner. Or even if you join an institute, so mostly you will be donning the leadership role, because right now in the current scenario, even if you join a academic institute or a hospital, you'll be mostly leading, or you must be heading a department if you are a postgraduate qualified family medicine doctor. And if you start your own practice, probably you will be leading a small team. So you have to develop yourself as a leader through this course of 3 years of post graduation, so that you function as a future family medicine, what is expected out of a future family physician. And AFP is an ideal platform to groom yourself, as to develop yourself as a leader. Uh, in fact, AFP has a tradition of grooming or breeding the young doctors into the leadership roles. Spice Route, which is organized this event today, the PG orientation, the first ever All India PG orientation. Although we have been having PG orientation programs at state levels, I think this is the first time we are having a national level PG orientation. The Spice Route, this I feel is the incubation center of AFPI to groom and breed, mentor the young doctors into leaders. So um, most of the doctors who are there, most of the Spice Route leaders now you're seeing, they all were like you few years back, and now they are leading the Spice Route movement. So you have an ample opportunity to um, develop yourself as a leader. Hello. I lost the thing. Was it anything centrally or was it a local problem? I don't know.
Focus and now you're audible, so we can start again.
Hello. Can you hear me now?
We can hear you now, sir.
Okay, okay. So I was just saying that Spice Route can be used as an incubation center for developing into a leader. And so my advice or suggestion to you is that please join AFPI. I think Dr. Vandana has already uh, mentioned what are the benefits of being a member of AFPI. Please join this network so that you are connected to a wide network of the fraternity, and you have an access to resources which are very useful during your PG days. We have a lot of activities which Dr. Vandana has mentioned, your CPD activities. We have CPD every month. We have case files. Spice Route is organizing a monthly classroom, which are very, very PG oriented, PG specific events. And of course, the state activities, the state CMEs generally cater for, in all the state, all of our activities generally cater for something for the residents specifically. So please join AFPA. And I'm telling you, you will not get this type of informal mentoring in any other specialty or any other association. So wishing you all the best. We want to see you coming out in flying colors as the future family physicians and future leaders of AFPI and healthcare system in India. Thank you so much for this opportunity. Just before I sign off, I just want to remind you that we are having 3 events coming up in each month, which are again catering to the needs of academic needs of PG students. The first one is in Karnataka. I'm from Bangalore, so I'm inviting you all to Mysore on 10th and 11th. We have a PG update on day 1 and a conference, which is also the scientific program is carefully designed to meet the requirement of both the PG students and the practitioners. Thank you so much. All the best.
Welcome so much, sir. And now we'll be moving ahead to a very important segment of AFPI, that is Spice Route India movement. And we have 3 important personalities from that movement with us right now. Dr. Serin Kuriakose, he is the Spice Route India chairperson. Then we have Dr. Jyotika Gupta, she is Spice Route India secretary. And we have Spice Route India FM 360 coordinator, Dr. Kailash with us.
Hi, good evening, everyone. Is my screen visible?
Yes, yes.
Okay. Good evening and welcome to the PG orientation program of 2022. Having been introduced to all the senior national executive members of the Academy of Family Physicians of India and some more interesting talks coming up, I also want to introduce all of you to the Young Doctors Movement. So this is the Young Doctors Movement under the umbrella of the Academy of Family Physicians of India. So this is called the Spice Route Movement. And this represents the young doctors of the entire South Asian community. So let me introduce myself. I am Dr. Jyotika. I am the National Secretary. We have Dr. Serin, who is the National Chair, and Dr. Kailash, who is the National FM 360 Coordinator. We will quickly introduce all of you to this Young Doctors Movement. It also becomes more special for all of you because by default, after joining your post-graduation, you all are members of the Spice Route and the Academy of Family Physicians of India. The only formal step left is to take membership, which I want to appeal again that please do take the membership after this orientation ends. Kailash, the slides are visible, no? It's changing?
Yes, yes, yes.
Okay. So by definition, a young doctor, a young family doctor is the one who is in family medicine training or the one who has finished 5 years of family medicine training and has started practice. So all of you are directly into this movement from today, from the moment you have joined this branch. There are various young doctor movements across the world. We have in Africa, the AFRIWON. Europe is Vasco da Gama. Actually, it has been renamed now to the European Young Doctor Movement. Then we have North America, South America, the Asia Pacific, Middle Eastern, where it's called Al-Razi, and the South Asian one called the Spice Route Movement. Officially, it was inaugurated in 2010 at the Kathmandu South Asia Conference. And the logo has been designed by our very own senior family practitioner, Dr. Ramnik Parekh. He is a senior practitioner from Mumbai. Dr. Raman Kumar, who is our national president, whom we heard a few minutes back, was the first chair of Spice Route India movement way back in 2010. And the first pre-conference was held in Mumbai in 2011. Currently, the Spice Route movement at the regional level, I mean at the South Asia level, has a South Asia Regional Council, which has the regional chair and the office bearers. Then this consists of 6 countries as their member nations: India, Pakistan, Bangladesh, Nepal, Sri Lanka, and Bhutan. At each country level, we have a national council. We have a chair, a secretary, an FM 360 coordinator. And from this year onwards, we also have 3 more members in the National Council, a treasurer, an editor, image editor, and a PG coordinator. Fortunately, from the past 1.5 to 2 years, we have been able to expand to each state chapter. So as Dr. Vandana mentioned, that AFPI has its presence in every state of India. Likewise, in about 6 states, we have also expanded the young doctors movement. So this is our core council. Dr. Serin is the national chair. I am the national secretary, and Dr. Kailas is the FM 360 coordinator. He will be telling you what this interesting FM 360 bit is. Dr. Serin, who is our national chair, is also the regional secretary for South Asia region. Apart from that, we have Dr. Gunjan, who is moderating today's session, Dr. Nitish, who gave us the introduction to our session, and Dr. Digbijoy is our PG coordinator. So what is the objective of setting up this entire Spice Route movement, which is guided by the Academy of Family Physicians of India, is to improve the education and training of the young family doctors, give them opportunities to develop skills in research, publications. And like Dr. Vandana has mentioned, Dr. Mohan has mentioned, we have regular national conferences, state conferences, as well as international WONCA conferences, which gives us an opportunity to present our research publications there. This Young Doctors Movement is a platform to share concerns, doubts, aspirations, and we all are here to answer all of those. Going back 5 to 6 years, rewind, we all did not have this type of forum. We did not have this type of access. Probably 1 or 2 states of India had the guidance, but most of us were unaware of whom to reach out to. But today that is not the case. And through all of this, we also want to encourage leadership by participating in various activities. So the activities of Spice Route India, we have various CPD programs, that is the professional development. Dr. Mohan mentioned that we have regular classroom sessions. At every national conference and now even a state conference, we have sessions and we have pre-conference sessions. We have Spice Route Cafe, which is an informal gathering to know each other and ice-breaking sessions. We have workshops, we have social media activities which are constantly going on, and we also have active research initiative. And through the Spice Route India movement, there is a waiving of the membership, rather the fees for publication in the journal of FMPC, that is JFFPC, the editor being Dr. Raman. So if you have to submit an article or your thesis via Spice Route, there is a fee waiver as well. These are our various state chapter leads. We have presence in almost 15 to 16 states. We have a special newsletter. We can share our newsletter details later on, and we have, which is run by our editorial team, headed by Dr. Swati, Dr. Sona, Dr. Nadeem, Dr. Bidyut, and Dr. Santosh. We have an important technical team, the one that has actually also been expanded now. They are the ones who are constantly working behind the scenes for churning out all the interesting creatives and posters that are released regularly for classroom sessions, for introduction of our members, as well as all the important events. We have a website, spicerouteindia.in, which has completely been designed by our national chair, Dr. Serin. So the Spice Route India, this particular office was installed in 2020 at AFPI Kerala. We have Dr. Kailas here on our left and Dr. Serin, who's the national chair. After that, we had a lot of online activities because 2020 was the famous pandemic year. And here we've had, just before the pandemic hit, we did have a few active physical meetings in Bangalore as well as Kerala, wherein the national chair, rather the regional chair, Dr. Sankha, who was from Sri Lanka, had visited us. We had a few meet and greet sessions in Bangalore, in Delhi, in Noida, and this was hosted at Dr. Vandana's clinic. which was an informal PG update, wherein all the postgraduates were introduced to AFPI and Spice Route, and it was a very interesting gathering at her clinic in Delhi. This happened this year in May or June. The national conference in Hyderabad, which was held this year in April, we had a panel discussion wherein we spoke about the various stages a graduate goes through from MBBS up to post-graduation and then into general practice. That was our National Council members. These were our activities at the national conference held in 2022. We also had a quiz organized for all the postgraduate students. These are our monthly classroom sessions. So we have called it a classroom because that's exactly what it is. We try to hold case presentations, which is done by a postgraduate student and which is moderated by a senior faculty member. So this is held monthly by different states. We have a webinar series which is currently ongoing on lifestyle management. We did have a workshop on poster designing as well this year before our conference. And before you think we are only interested in academics, we actually had an online cultural event last year, which was an open mic in July. We had singing, dancing, poetry recitation, and many more such activities online. This is the way we celebrate various important days like the World Family Doctors Day, International Nurses Day, and various important events, global events. These were our online events which were held in the year 2020 and 2021. We have regular meetings, not only at our national level, but we are also supposed to attend meetings at the South Asia level. This is our website. Please do visit spicerooteindia.in and you will be able to get all details about AFPI and Spice Route India on that. This is our newsletter. We have had 5 newsletters till now. Everything is available at our website, bulletin.spicerooteindia.in. This is the Journal of Family Medicine and Primary Care. The editor is Dr. Raman. And like I mentioned, there is a fee waiver for those of you who would want to submit articles via Spice Route to the JFMPC. We have various social media campaigns. The first one wherein we introduced almost every young doctor who was active in the country at that moment, starting from Jammu and Kashmir to Kerala, to Gujarat, to Karnataka, everywhere. And this was a very unique campaign that we ran for almost 2 years, and we introduced almost 85 to 90 members. Currently, we are running this campaign where we are introducing the institutes of family medicine. So it's called the Splendid Schools of Family Medicine. We post these flyers every Tuesday, every second Tuesday of the month. So everyone can get to know of the various institutes that are present in our country, which have family medicine as their subject. Mumbai, Kerala, various states have been represented. These were our lockdown events. This year, we have started what is called the Spice Route India Rising Star Award, which was awarded to Dr. Nitish Garg from Muradabad. And the Kerala state won the Spice Route India Best State Chapter Award at the recently held national conference in Hyderabad. We have a strong tie-up with medical students also. 2 associations, that is the Medical Students Association of India, as well as the South Indian Medical Students Association, wherein we are trying to reach the grassroots level and trying to bring awareness about family medicine and its importance. We want to bring back the family doctor to the community. And it's a proud moment wherein we have been able to expand our state councils, and in Kerala, Karnataka, Delhi, Telangana, Tamil Nadu, and Maharashtra, we have not just our state leaders, but we have representatives to manage the activities at state level as well. With this, I also want to call Dr. Kailas, who is our National FM 360 coordinator. He will tell us about the important vertical of Spice Route, that is the exchange programs.
Good evening, all. I think I'm audible to all of you. Myself, Dr. Kailas, a specialist family physician from Kerala. I would like to introduce you all about the FM 360 program run by the AFPI Spice Route India movement. And this FM 360 program is basically a global international exchange program for the junior family doctors and general practitioners. That is into the 5 years of after completing residency, who would like to experience primary healthcare from a different country. And it started in 2013 at the 20th Wonka World Conference in Prague. The first meeting for establishing a formative exchange program happened. And this exchange program exists only because there are intercultural exchanges enable people to come closer and help junior FM doctors to learn from each other's experience, problems, and solutions. Senior hosts can teach their experiences, their viewpoints to the visitors, and also learn from them. So in this way, it is a give and take for both the host and the visitor. So with this introduction, I will just go to how FM 360 program works. That is, if someone wanted to visit some other country, they have to contact their regional the FM 360 coordinator of that country, and he will contact the FM 360 coordinator from the respective country which they have to visit. And the visitor and the host will be put together, and they will plan. An objective will be planned by the visitor, and which is agreed upon by the host. And this with this program runs between around 2 to 4 weeks, depends on the availability of the host. And the visitor has to submit his application around 6 months before the proposed exchange date. And all of the cost for the exchange programs has to be paid by the visitor itself, and the Spice Route India movement, and also the FM 360 program coordinators from different countries help them in getting a cheaper visit to the other countries. And they have to abide by all the rules and regulations of the countries they are visiting. But India being a large country, you have to there are so many it is a second most populous country in the world, and each state and region in India is different from each other, and speaks its own different languages. And culturally also there is a lot of difference between different places in India. So the challenges faced by a primary care physician in each and every part of the India also differ. So in that viewpoint, the Spice Route India movement has planned an interstate or intercity exchanges specifically for the Indian scenario, and these are called by us as this micro exchanges. So this is the basic output of FM 360 programs. And with this, I am concluding within a short span of time to go to other interesting sessions. So before I stop, I appeal to all the young family doctors who are recently joined to join AFPI and be a part of the Spice Route India movement and all the activities in it. Thank you.
Thank you, sir. Now we will be moving ahead to our next session, where I'll be inviting a very esteemed teacher, academics wise, as well as motivating young physicians to do well in practice, morally, as well as through their knowledge. Dr. Sunil Abraham, he has done his MBBS and DMB. Thereafter, he did FRA from Melbourne. He has been running a low-cost 48-bedded unit of CNC for urban poor, which is one of its kind, and he has been involved in a lot of academic sessions for the PG students. Sir, let's listen to you. Sir, you're not audible.
So you're on mute.
Okay. Good evening, everyone. Really happy to be part of this meeting today. And as Dr. Mohan said earlier, congratulations to all of you for taking up family medicine. In fact, these are really exciting times. You know, the AIMS are going to start a new MD in family medicine soon. In fact, the curriculum is ready, and the government is actually, the Niti Aayog personally has been pushing for it. PGI Chandigarh is going to start an MD in family medicine. And of course, the new change in standards for the community health centers, where the Ministry of Health has said family medicine specialists can be specialists in the community health centers. So a lot of exciting things happening, and really congratulate all of you for taking up the specialty of family medicine. But the question is, your training is only for 24 or 36 months. And your training time starts from day one. And it'll run very quickly. So I want to briefly touch on how do you best use your timing when you're in training? Because when I speak to residents, like at the Madurai conference, about 1/3 of the conference participants were trainees, which was really exciting. But you also hear the stories of struggles people go through and the lack of, teachers, etc. So the 24 to 36 months, whether you're doing a diploma or the 3-year DNB or MD, is a time of intense work and intense study. And I wanted to look at it that way. This is one time when you're going to see large number of patients and diseases concentrated in one place. So do your very best, because once you finish your training, you're not going to get this. You're not going to go get large number of patients under the safety of other consultants to learn from. So you have to really plan your training time. So I just want to briefly touch on your theory. How do you plan learning during your training? Looking at the domains of your theory, hands-on learning. I don't want to do much on research and learning to pass the exam because others are going to look at it. But basically on these two things. Now, with regard to the theory, one thing that you need to have is to have a journal club. So when you're in MBBS, let's say you're learning medicine, you take Davidson or you take a handbook and you mug it up, go for the exam. Now, this is different. You are training for your career, and you should learn what is current, what does the literature say, what are the new trends, what are the guidelines. And once you know them, you can be as confident as anybody else. An endocrinologist might put something on a patient for diabetes. And if you are current in your knowledge, you can confidently even challenge some of them, say, no, that's not the current guidelines. So have journal clubs, organize them. If you don't have it, among yourself, do it. You must realize that your postgraduate trainees get together and organize journal clubs, because they put you on the cutting edge of what is happening. There are a lot of online resources, like National Board has got a webinar series where you can attend. This happens every Tuesday. Unfortunately, the timing is a bit difficult, but that's only the time slot that was given to family medicine. It's from 4:30 to 5:30. It covers a lot of topics. And I tell you, some of these topics come for your exams. So attend these seminars. AFPI has got a lot of sessions, like the spice route they were talking about. Go for the conferences. Last year in Chennai, we had a conference for trainees when people came and interacted with other residents. And that was very, very encouraging, and learning from others. The other thing which I would strongly recommend is the Royal College of General Practitioners International Affiliate Membership. So it's only 35 pounds a year, which is just about 3,000 rupees a year. And you get access to all their resources, all their training programs, which is all current, well developed for the GPs in the UK. And these are very good stuff that you can use. Now, with regard to your learning, as I put, textbook should be last. Your learning should be mainly from journals. We have our own journal in India, the Journal of Family Medicine and Primary Care. I often check the American Academy of Family Physicians. And even today I had some doubt, I checked it, and the Australian Journal of General Practice. Now, learning from these journals is good because it approaches the issue from a family physician's point of view and not from a internal medicine's point of view or a pediatrician's point of view. So it gives you an approach which will be useful to you for your learning of your theory and also for your practice. And you understand, okay, how do I approach this problem? And what are the investigations I do? When do I refer to a specialist? What are the things I should be careful about, etc.? So keep your tabs on journals. And I want to tell something else. Make learning part of your daily work. Do not separate this. Do not compartmentalize these. As you see a problem, learn from it and learn the same day. And don't keep for theory studies as preparing for the exams. That is MBBS way of learning. Or do your postgraduate training. So make it part of your daily work. So I want to share something called puns and dents. A pun is, let's say you see a patient and you see something you don't know how to handle. Now that becomes a patient's unmet need. You realize you don't know. Now that is good, because as your knowledge grows, they say it's like balloons. As it becomes bigger, you hit new areas where, oh, I don't know this. And that happens to me every day. I hit areas where, oh, I don't know this. It's an unmet need. And that becomes my educational need. And I read about it straight away. That's how we learn over your course. You keep on learning. You keep on learning every day, and it helps you. And as one professor from CMC Ludhiana said, if you are not searching PubMed at least once a day, you are not current in your knowledge. That means you are falling back. So he encourages all his PGs. You have to learn. What did you seek today? What did you learn today? What did you search? I have no issues about sitting in front of patients and looking at my Google on my mobile and say, let me find out, and telling him, look, this is what is current knowledge about, because we just cannot learn or remember everything. We just cannot keep on par with what is happening and the current thing for everything, for every subject. And family medicine being so vast, you don't have to feel ashamed about that. In fact, patients will respect you knowing, okay, you're trying to find out what is best. But the point here is keep learning as part of your work every day. Coming to hands-on learning, one thing that you must do right from the beginning of your course is know your curriculum. What is the curriculum that has been prepared? Dr. Raman and others prepared a fantastic curriculum for the DNB, and there is curriculum for the diploma and the MD. Look at what are you supposed to learn? People ask, what do you do in family medicine? Look at the curriculum. And for each rotation, like let's say you go to pediatrics, you should know, what am I supposed to learn here? MBBS, it was pediatrics posting. You have some classes, you have some theory, finish, an exam over, then you go to the next one. But here, this is about your speciality. This is what you're going to practice. So you must look at, okay, what does the curriculum say? Get the specific learning objectives. If you don't have specific learning objectives for that rotation, contact AFPI. I'm sure there are people who can help you to form them, so that when you go for a rotation, you know very clearly, this is what I'm supposed to learn, and you focus on that. And learning happens throughout the course. No, you must not think that, okay, I have a 2 weeks orthopedics posting. What will I learn in 2 weeks? It's not just in 2 weeks. You learn over 3 years. When you're in your community health posting, or when you're in a general practice posting, you might see a patient with a backache and you see how it is being managed. So the learning happens throughout. You're referring your journals or your book or guidelines happens throughout the course. It's not just compartmentalized. So, and the other thing which I was telling some PGs is, they say, you go for a rotation, there is no one to teach us, people don't want to teach, there is nobody who knows what family medicine is. These are realities, especially with the diploma which was started last year. I understand that many places there is no regular sessions, it is a struggle, but most of the places, there will hopefully be one person who wants to teach. So you must realize that especially district hospitals which have started the course, these are people who are just working as consultants for many years. Suddenly they are told you have to teach. And you have to teach a subject they haven't learned. It's family medicine is new. But you should look for someone who is willing to teach you and go after that person. Because unlike undergraduate training, you have to take the lead. You should take the lead and go forward. Go after your teachers. I would say go after your teachers. See, as a teacher, if somebody comes and says, can you please teach about this? I'll be very happy to teach, because I know that somebody is interested to learn. So show your interest. There might be other DNBs going on, but you as family medicine people show that, look, you are proactive about learning and go after your teachers. Volunteer to do things. Don't stand and think people are going to come and give you things to do. And, as somebody said, I'm seen as filling the blanks. I remember when I did my DNB, single day I worked in 4 OPDs, because there was a shortage here, there was a shortage here. So where I looked at is, oh my goodness, I'm a very valuable person. I'm needed in multiple places. And I also learned. So there will be a consultant there. I asked them, look, how do we do this? How to manage? You can change your attitude. I know it can be discouraging sometimes. I know you feel that you are just being used, but use and see what can you learn. Use it as an opportunity. Ask questions. And when you see an issue, ask yourself, hey, how do you do this? A patient comes with pain in the wrist. What is it? Is it DQ and synovitis? If it is DQ and synovitis, what is the test that you do? What is finger strength test? How do I manage this? How do I manage it conservatively? When do I have to refer the patient? Learn. Actively learn. This is the best way to manage this. What does the current evidence tell me? What is the current management for patients with microalbuminuria? Which oral anti-diabetic drug should I give? Do not compartmentalize, but keep on learning. Keep on learning throughout your course. Attend the webinars, join the AFPI seminars, and I would say no point complaining. You have 2 or 3 years. Don't waste your breath just complaining. It's not going to change anything. I'm sad to say that we are giving feedback. In fact, we've been giving, even last week I was at the national board and I gave some feedback about the situation in some of the places. But join others and learn together, because the onus is on you. Don't wait for things to happen. There is something called reflective learning. See, earlier people used to say, you see something, you do something, and you teach somebody, you learn. But educational specialists are saying that unless you reflect, you are not learning. So you can see 30 patients a day and go through the day and without learning much. But unless you reflect on, hey, what did I learn today? Like today, I joined a bit late because I'm on call in the ward in the family medicine department. We have a 48-bedded hospital run by the family medicine department. There was this lady who was referred from elsewhere. She's a diabetic hypertensive. Outside ECG had some ST depression. They said, have to be referred. So she came, she was sweating. So ECG showed the thing. But then as she was sitting, she just sort of collapsed like that. I asked them, have you checked the sugar? The RBS was 50. So, you learn on, okay. Then I told him, look, this is a learning point for you. You learn from things like that. Every patient has something to teach you. They are your teachers. So reflect on what are the challenges that you face. I reflect on mistakes I made or diagnosis I missed, because you keep on learning throughout life. Also learn from your peers, learn from your seniors who have gone before you, learn from the second years or the third years, and find out who are the good people in this department who will teach. What should I do to learn the best in this department, etc. Learn from your seniors. How do they manage this? Because the practical management can be quite different from what textbook says. I would strongly advise you to do the BLS and, if possible, the ACLS training. And recently, in Bangalore, they had the BLS training. I'm not sure whether they had the ACLS training, which is fantastic. That accredited training is being offered by AFPI. That will give you the confidence, wherever you are, to get into an emergency and help out. Learn procedures during your time. Learn to do. If you don't know how to do a proper suturing, bug the seniors and go after them and learn it. If you have to do an IND, local anesthesia, etc., simple things which you can manage. Learn about teamwork. Family medicine is a different specialty, and you need to learn from others. Learn from seniors. How is this different? How is it that it's so different from what we saw in MBBS days? Because, all those who are established family medicine practitioners, they will say, there's no specialty like this. Absolutely. We just enjoy it. So about the thesis, I don't want to talk much, but I just want to say, keep it simple. You're not doing a PhD. It's a simple thesis. Make it simple and finish it off as quickly as possible. Preparing for exam, check all question papers. Practice writing answers. Very, very important. After your final MBBS, you may not have written an essay or exam, but practice writing. That is very important. Again, there's a session on exam. I don't want to talk much about it, but you have to practice presenting patients. I tell you, for your final exam, you'll have medicine, pediatric, surgery, and OBG cases. So you must know how to practice them. If your teachers are not ready to teach, present to yourself, because ultimately it is your exam you're going to face. Read textbooks on clinical medicine and make your basics. There are some medicine examiners who will come, who will just ask about pulse. What are the different kinds of pulse? How do you do a reflex? And then they will say, what is this? They don't know even the MBBS things. Get your clinical medicine foundation very, very clear. And I want to say, do not get discouraged. Do not get discouraged. You have chosen a good path. I can tell you, after so many years in family medicine, I can't think of doing any other specialty. But you need to plan your training and how to get the best about it. And I would say again, don't waste your time. Already your course is started. And every day that you're moving forward is one day less. So use your time well. And remember, I think this is one challenge I faced. You are not just junior doctors. You are not just junior doctors working in different departments. You are postgraduate trainees, preparing for your career. So wish you all the best and hope you have a good time learning. Please join, be part of AFPI. There is a wealth of information and wisdom here and resources. There are plans to have a national platform for PGs also. So wish you all the best. Thank you.
Thank you so much, sir. And now we'll be moving to our next session, that is what we need to focus during our specialty posting. We have Dr. Reshmi for us for this particular session. She is a senior consultant and HOD of Department of Family Medicine at Lotus Hospital at Kochi. She is also National Treasurer for the AFPI company. Welcome, ma'am. Ma'am, you need to unmute.
Yeah. Good evening, all. After hearing Dr. Sunil's talk, I think I would like to do the DNB once again with all these tips in mind. I feel I've wasted 3 years of my training now. Going on to the next topic, which is almost very similar to what Dr. Sunil sir has discussed already. So this is about the specialty postings during family medicine training. So actually, family medicine is unique that you are not just being trained in the specialty that you have chosen for. You're going to various departments during your 3 years or 2 years of training, and it is lots of confusion, lots of inferiority complexes running, so much of doubts going on in your mind. So now there are the curriculum, as Dr. Sunil sir said already. You have to be thorough about you have to know what your curriculum is. So DNB has now separated the training into 6 modules as family practice, general medicine and allied specialties, general surgery and allied specialties, pediatrics, OBG, emergency and trauma, and electives of 2 months depending on the institution of your training, what are the facilities available there. MD has another curriculum set by the NMC. Now DFM, or the Diploma in Family Medicine, which has started last year. Now I think it is the second year that students have been taking DFM. So in that there is a little bit of difference that it is in 2 years. So the duration has been reduced compared to the DNB. Still all the rotations are there. So now, as Sunil sir rightly said, there should be specific learning objectives or SLOs. So you should know what you're supposed to learn from each of your rotation. So you should know the knowledge that you should acquire, the skills that you should be acquiring during each specialty posting. So there is a comprehensive and at the same time very exhaustive list designed by NBE and NMC. So I request all of you, all the PGs, to go through the site website, DNB website, NBE website, and you can see the curriculum, and they have very clearly mentioned what you are supposed to learn in each during each rotation. So be familiar with the SLOs for each area, but being familiar is not enough, because your institution, some department may not be doing some type of work. So you should also know about the work done by all specialty departments of your institution. You should know your institution well, know all the departments in your institution very well, and know the faculty who are, like sir said, who are interested in teaching, who can be approached for a specific problem, who is an expert in what, all those things. So now when you join a PG program, your expectations are that faculty in other specialties know very well what family medicine resident needs to learn, and very well we are going to implement all SLOs. There will be a supervised learning of procedural skills, academics, and assessment after each area, and guidance on improvement. So with all these expectations, when you go to a specialty posting, what happens, reality strikes, absolutely no idea about family medicine for faculty in other specialties. Even after running family medicine course for many years, many of the institutions, the other specialties, do not know what family medicine residents are supposed to learn, or what they are supposed, how they will be practicing, and what is important for them. So sometimes they're being used as cheap labor, as we call it, more of clerical work, discharge summaries, all those things. And you don't find academics as expected. But what is academics? That is what we'll discuss next. What are specific, they'll ask you what are specific learning objectives. They would not have heard about it at all. And the only exams that you go through will be the formative assessment tests that NB conducts every year, and the final exams. So there is no assessment in between also. So now what happens when life gives you lemons, make lemonade out of it. So you should know your own strengths and weaknesses. What area I am weak, and what area I should improve. All these things you should very well know before you go to a specialty posting. Only then you can improve on the skills that you need to acquire. And explore your opportunities. As Sunil sir rightly said, nobody is going to come behind you to teach or spoon feed you, because you are not school students or MBBS students anymore. You are postgraduate trainees who, after an exam, after the exit exam, you are supposed to treat patients. So you have to explore your opportunities. You have to take the lead. No one is going to come behind you. You have to be always anywhere in the hospital, in the OPDs, wards, ICUs, emergency department, labor room, or OT, wherever you get a space, you have to be there and learn from there. And you have to be open to learn, ask, and clear doubts. If you keep your doubts in your mind, you'll be a fool forever. But if you ask a doubt, however silly it might be, only for that moment you will be called as a fool. But the next moment you get the answer and you are not a fool anymore. But if you keep that doubt in your mind, you are not going to learn anything. So be open to learn, ask, and clear doubts when you go to each rotation. And interaction between your own colleagues, because somebody would have gone before you to the specialty posting. So you could ask them, you could ask your seniors, and there may be residents of the other specialties. Where you go to the posting, there may be other residents also who are being trained in that specific specialty. So you can discuss with them, interact with them, and try to learn from them. And you form your own study and discussion groups. There is no point in complaining, as Sunil sir said, that we have no academics. Academics is what you make. You have to form study groups, you can form discussion groups, and you can update yourself on the knowledge. There are so many seminars, lectures, case presentations, and journal clubs that you can organize among yourselves, in addition to the resources that AFPI and Spice Route provides, or other conferences provide. You can conduct among yourselves. So during specialty postings, consider every patient you see as a learning opportunity. Patient should be considered as a learning opportunity to you. One of my residents a few years back asked, I always tell this in all the PG orientation programs, that one of my residents asked the HOD of a department, sir, which book should we read? And sir's reply was that patients are your books. Simple. That was the reply that he gave. So each patient is a learning opportunity for you, and try to achieve as many learning objectives as possible. You would have gone through the SLOs, and you know what you're supposed to learn. So try to achieve as many of them as possible within the limitations of your training institution. And after your training, if you feel that there is a lack in some area, you can update it after your course also. Learning does not end with a PG program. So understand what is important for your practice as a family physician, not as a system specialist. When you go for a posting, when you go for a rotation, you see that they are dealing patients as a system specialist. But what we should imbibe from that is that we should know how we are going to manage it when we are in a resource limited setting or when we are running our own clinic. So what is important for you as a family physician, that you should understand. From every patient, every case that is managed, every patient that is managed, you should try to extract what is important for you and acquire procedural skills as much as possible. And to every knowledge that you acquire from every other area, you have to integrate the principles and concepts of family medicine. You should go through the concepts and principles of family medicine, not the theory, but you should practice this daily. In every patient you see, you have to practice the concept of family medicine, and then it becomes a way of life. Then it becomes a way of your practice. So even during the specialty postings, you need not feel an inferiority complex, or you need not compare yourself with the other residents of that specialty, because they are learning a different specialty. Your specialty is different. So you have to acquire knowledge from them and put family medicine practice into it. It is a like you have to, like sir said, you have to take it as a, not as a fill in the blanks, but as a learning opportunity. Now, for example, I've just lined some patients who might be presenting to each department, just examples. What all specific learning objectives you can learn from each. Now, you're posted in a general medicine department and you see a diabetes patient who was it can be a newly detected, or let us say if it is a diabetes patient on follow-up with who is admitted with uncontrolled diabetes and now is having diabetic nephropathy. How will you, what will you learn from that patient? You need not just go and write the admission sheet, keep the discharge summary prepared for the discharge date, just go through the investigations, copy the investigations and write it and parrot all the treatment that the consultant has given. No, you should know why this patient is having an uncontrolled diabetes mellitus. You should take it as an opportunity to educate the patient regarding diabetes, the diet and exercise, lifestyle modifications, the medications. You can talk to the patient, you can see why he or she is having an uncontrolled diabetes, thereby enhancing your communication skills. One specific learning objective is achieved there. Your communication skills, your advice to the patient, and you see what are the medications being prescribed, why is it being prescribed. You ask the consultant, why sir this is being given, this is what we learn in textbooks is this, but you are giving this, why? So there will be an answer for that. So learn from that. What are the medications prescribed, how is it prescribed? So prescribing medications, rational prescription of medications, that also we have learned. And then the complications of diabetes mellitus, how to identify the complications, what are the investigations you will do in a diabetic patient. All these things are different set objectives that you can learn from a single patient. So you need not take it as a going behind the consultant as if you're going like you don't belong to there. It is not like that. You can learn from one patient, and see, I have not mentioned all the SLOs that you can learn from that, but from one patient you can learn so many things. You can achieve a lot of learning objectives from one patient. Similarly, in general surgery, if you see a swelling on the upper back, you can learn how to differentiate, what are the differential diagnoses, how you will arrive at a diagnosis, how will you examine a swelling, all these things, and how you will manage the swelling. If it is a sebaceous cyst, how to do excision of the sebaceous cyst. If it is an abscess, how do you do IND? And then what advice will you give to the patient? What are the post procedural complications that this patient can have, and how will you give anesthesia, local anesthesia to this patient? All these things you can learn from a single patient. It is not like you go do it and come back and don't ask any questions. You see somebody doing and you hold your hands and wait and see. So similarly, I've just lined up all these cases. I don't think there is time for everything, but Finally, what I've written is about the community health center or the home visit when a patient comes with multiple vague complaints, vague symptoms, and you have to integrate all these. When you, in your family practice, you have to integrate all this knowledge that you've learned from all these specialities and learn to diagnose, communicate with the patient, treat the patient, and follow up the patient, prescribe medications, all these things. So from each specialty, you can gain what is important for you and put into practice once you enter into clinical practice. Now, there are some frequently asked questions. Which textbooks should I read for each area? The moment a student joins DNB Family Medicine, the question I hear is, Madam, what is the book for medicine? What is the book for surgery? See, as Dr. Sunil said, there are textbooks which we have gone through in the medical MBBS curriculum. There are other textbooks also, but primarily you update your knowledge through all sources possible. It is not just a textbook reading. There are standard textbooks which you can refer to. There are journals which you can refer to. There are other articles on net which you can refer to. And then there are two textbooks of family medicine which I would recommend. Is John Murtagh's textbook of general practice and Rakel's textbook of family medicine. You can go through that to have a comprehensive approach to all the symptom-based management is mostly stressed in those textbooks. So more than textbooks, it is a continuous learning. It is not just from the textbooks. It is all these sources plus the patient themselves. And how much to learn in depth regarding each area, that is a confusion. Will they ask medicine? That is because you think in exam point of view. The day you join DNB or diploma, you think about the exam, whether I will pass this. So if I have to pass, how much should I learn in depth? Should I learn like an MBBS student, or should I learn like a PG of the internal medicine PG or a OBG PG? No, you should learn enough for your practice. You should learn, keeping in mind that you have to practice as a family practitioner in your area or your community or whatever you're choosing, wherever you're choosing to practice, and what is needed for that area, how much knowledge. No knowledge is enough. So you can acquire as much knowledge as possible. Is exam-oriented learning and practice-oriented learning possible simultaneously? Is it possible? Yes, it is possible. It is not. It has not to be compartmentalized, as Sir said. You have to see patients and you have to learn from patients. You have to learn, integrate both the theoretical exam-based knowledge into your practice-based learning also. It is possible simultaneously. The last question is a question that was asked in the National Family Medicine Day, on the National Family Medicine Day when we had a seminar. One of the DNB residents surprisingly stood up and asked this question. After rotation in a specialty, when I go to the next, I forget the skills and knowledge acquired in the previous rotation. How can I overcome this? So what are you learning? Are you learning pediatrics when you go to pediatrics posting for 3 months and you forget it there and then go to OBG and then totally forget about children and start managing only women? No, that is not the case. You have, like Sunil sir rightly said, the learning, you have to integrate all these. You can learn continuously. You are in a hospital where there is a pediatrics department and an OBG department. You need not compartmentalize, saying that when I'm in OBG, I'll see only OBG patients. I will learn only about OBG. No, you can see the other patients also who are there in pediatrics department or medicine department, whatever confusing patients or whatever important patients are there. You can, important in the sense learning opportunity. You can know it from your colleagues or seniors and learn from them. So it is not stopping at that specific rotation. It is a 3-year process, and then you are not going to forget what you have learned. If you're going to forget what you learned, it means you have not learned at all. So all the best to all of you. I hope I have answered some of your doubts. The most important thing is be confident, and wherever you go, you keep in mind that you are training to be a family physician. Thank you all, and all the best to all of you. And if you have any doubts, you can ask.
Thank you, ma'am. Now we'll be starting our next session, that is how to prepare for examinations. We have Dr. Srinivas with us for the same thing. He's Dean of Academics with AFPI and a member of National Executive, founder of AFPI Telangana, State Chapter, and Chairman of the Scientific Committee. Welcome, sir. We would love to hear you. We are running short of time, so we can concise the session, sir.
Thank you, Gunjan. Today's my topic is learning objectives and the groundwork for the examinations. Actually, the topic being given is preparation for the exams. Just I have modified the title. I will deal with both the theory and the practicals. Actually, Reshmi has dealt very extensively what the duties and the responsibilities of the PG residents, and she has made my task very easy. First, we have to we have to go through the revised syllabus. First, know the syllabus and curriculum. This is being given in the DNB guidelines for competency-based training program in DNB Family Medicine 2021. So be thorough with, just go through the revised syllabus and curriculum. First thing. And next I will come to the theory examination. You may be having a great knowledge. You might have read so many books, a lot of knowledge, but the exam-oriented preparation is one thing, and you should know the pattern of the question papers. Only then you can pass, you can come out in bright colors in the exams without any difficulties. So that is why we should know the question paper pattern and the distribution of the marks. Mainly, I'm dealing with the DNB Family Medicine final year examination. It is two-stage exam comprising of theory and practicals. There are 4 papers in the theory. Paper first is medicine and allied subjects. Second paper is surgery and allied. Paper 3 is OBG and pediatrics. And 4th paper covers SPM. Go through the question papers of previous 8 to 10 years. Work out these question papers. Practicing with question papers will give you an idea of your progress of exam preparation. And if you analyze 2021 DNB Family Medicine final year question paper, suppose if you take the internal medicine, the topics are the case scenarios are the ones which you are all familiar with, where you see day in and day out during these next 3 years. All the common disorders, they are being given. And suppose in the medicine, they are in 2021 DNB Family Medicine final year question, the 10 topics were heart failure, acute viral hepatitis, hepatitis A, vitamin B12 deficiency, psoriasis, depression, CKD, coronary artery disease, urinary tract infection, dementia, post-COVID syndrome. These are all the common topics, and COVID is a current topic. So not only the medicine, all the second and third paper and all the papers, you will be familiar with the common disorders. So the exam-oriented preparation involves 3-year clinical study and knowledge, and not the book study alone. The students learn at the bedside, guided and instructed by experienced teachers, and inspired towards self-directed, diligent reading. It is not just a 2 or 3 months preparation. Exam-oriented preparation involves 3-year clinical knowledge, clinical study. So involve yourself, as Sunil Abraham and Reshmi has clearly told. You participate actively in OP consultation, in inpatient ward rounds, seeing referral patients, procedures, bedside case presentations, night duties, topic presentations, journal clubs, clinico-pathological meetings, seminars, symposiums, grand clinics, and ward rounds. So be active in all these spheres of activity, then you will be well prepared for the final examinations. The next thing is, the most important thing is, the residents should develop a systematic systematic approach for an effective clinical problem solving. You must have a concept regarding an effective clinical problem solving. If you read chapter 11th from Rakel textbook, you will have an idea, because the principles of family medicine define the context for solving clinical problems of whole person, comprehensive, first contact, continuous, and team-based care. There are 5 dimensions of being a human being, which are physical, psychological, social, spiritual, and chronological. So family physician should have an understanding of these spheres, these dimensions of the human being. And we are the first contact. The patient comes, the disease is undifferentiated. You are the first contact. So you should have the knowledge of these things. You are a comprehensive care. You have to render comprehensive care. You have to give the preventive care. You have to give the therapeutic care. You have to give the rehabilitative care. You have to give the palliative care and wellness. So you have to work in the clinic. You have to work in the hospital. You have to visit the home visits. And it's a part of teamwork, actually, on one aspects. So these are the various aspects. These aspects you should have an understanding. You should have a clear concept of the family medicine, where we differ with other specialties. What is the art and science of family medicine? It's a unique specialty. It's unique characteristics, unique peculiarities. For having an understanding of our family medicine, you must read a textbook. That's very, very important. And the best textbook is Rakel. If you read from the day one, you will become, not only that you come in bright colors in the exams, but you will develop into a fine family physician. So textbook is very important. Instead of reading so many books, just like suppose Parsons, these are the Logan and Turner ENT, and Mahesh is orthopedics. Instead of reading so many books, you base on single textbook, which is comprehensive and which has dealt very nicely, which you will give you a good concept. That is Rakel alone. That is what my personal feeling. My advice to the residents is to mainly on the Rakel textbook. And I just now I have mentioned about the chapter 11 of the Rakel textbook, which gives an idea about the effective clinical problem solving. If you are involved in this activity, you will be thorough in writing theory examination and the practical examination. The principles of family medicine define the context for solving clinical problems. And the clinical problem solving involves beginning to understand the problem in clinical terms, define the problems to address, that is the diagnosis, formulating a solution is the treatment and management plans, and monitoring the response. You ask your teacher to conduct written examination once in 3 months. And you should be thorough with the latest guidelines and updates. And you should utilize the FAT examination. That is formative assessment test. DNB board is conducting the FAT examinations 2 or 3 times. This is during the course. This examination will be in the course, during the course itself. It's not a summative one. Summative is the final examination. It is a good exercise. It is just like a rehearsal for the final drama. So you utilize this FAT examinations. Almost it is similar to the DNB final examination. They are conducting both the theory and practicals, and the examiners are the external examiners. And you will also get the feedback. That's very important. And what are the positive aspects, what are the negative aspects, the examiners will convey to your faculty, and the faculty will convey to you all the negative and positive points that you have. So utilize the FAT examination. And examiner preparation first have an idea about the questions. Generally, in the final year questions, what I found that there are generally 2 types of questions are there. Straightforward topics are being given, and they are also giving case scenarios and questions. It is these case scenarios are practical, real life encounters. what you see in the ward, what you see in the outpatient, inpatient settings. And they are not given in the textbook, any textbook. You have to learn from the patients. You have to learn from the practice experience only. So they will give a case scenario and they will ask 3 or 4 questions. They will mention the marks also. So straightforward, when dealing with a straightforward topic, you write an introduction, definition, clinical features, investigations, management, conclusions, etc. And you answer to the point, be specific, answer all the questions. Time management in the exam hall is key to success. You all know very well. And the presentation is very important. It actually differs from the undergraduate level presentation. The presentation should be more diagrammatic, figurative illustration. It should consist of flow charts. You have to, by which you can mention so many points. And don't write big sentences and paragraphs. You can use the color pens to highlight the important aspects. Write headings and subheadings. That will immediately, the examiner will be attentive and he will come to know what exactly the content, the depth of the knowledge that you have. So don't write paragraphs and sentences, and flow charts, algorithms, be perfect. Actually, we used to see, if I remember correctly, there is a Manipal's Manual of Surgery in which there is a diagrammatic representation. Almost most of the topics were given diagrammatic. Even hemorrhoids was diagnosis, and so many aspects were illustrated diagrammatically. And such books, if you go through such book, you will have an idea how to present the cases. Presentation is very important. And next book is, these are all the various textbooks. And Reikal textbook is the one which is wonderful textbook. You will have a good idea of, if you read Mudaliar, Parsons, Logan Turner, Maheshwari, Park's textbook, and Short Practice of Surgery. And the last two, Swanson's Family Medicine Practice Review, a problem-oriented approach by Talia and others, and NMS Question and Answers, Family Medicine by David Rudy. If you read these two books, they will give a case scenario followed by the multiple choice question. They will give the 4 options and they will ask you to tick which one is the correct one. Just for having an idea about the case scenarios of various diseases, better you follow these books. These 2 books are available in the Amazon. You can get this. That is Swanson's Family Medicine Practice Review and NMS Question Answers, Family Medicine. So theory examination, you plan, have a strategy, time schedule, and study methods. Keep reading about the diseases that you encounter in the wards. Prepare your own notes. It facilitates quick revision at the time of the exam. Utilize the information given in internet sources, in the journals, and as Dr. Sunil Abraham has clearly told you, utilize the internet and the journals also. All the information given, utilize it, concentrate, and before the prior to the final examinations, concentrated for 2 or 3 months exclusively on exam preparation. And no other extracurricular activities or nothing else. At least 2 to 3 months, if you exclusively concentrate on the exam preparation, you will definitely come out in bright colors. And you get the leave for that exam. You get the leave for that period. Prepare your timetable or plan and stick to it. And collaborative and learn, collaborative and cooperative learning, group study. Because whatever the knowledge that we get is 1/3 is from the teachers, 1/3 is from our peer groups, and 1/3 is from our real practice and experience. The knowledge comes from these 3 sources. So a group study is definitely advantageous. That is what is popularly known as collaborative and cooperative learning. And sharing, you share whatever the knowledge that you have with the peer groups so that you remember well. So revisions and recollections. And more you revise, more you remember. Not only the revisions, after just simply reading and keep the book aside, it won't work all the time. And suppose if you recollect the matter, it can be retained for a longer period. So recollection is very important. And recollection of that subject is very important. And more you revise, more you remember. Next is, this is the theory part I have told you, just 5 minutes more regarding the practical examinations. Coming to the practical examination, DNB final year practical examination, make a list of the exam cases. For example, respiratory cases, they may alert any of the below cases, like COPD with or without carpulmonale, consultation of the lung, pleural effusion and empyema collapse of the lung, cavity fibrosis, bronchiectasis, bronchial asthma. Similarly, make a list of the cases of other systems and other subjects as well. Suppose in the pediatrics, you will get any one of these cases, any one or two of these cases: short stature, failure to thrive, microcephaly, edema, jaundice, pallor, lymphadenopathy, hepatomegaly, splenomegaly, giant pain, floppy infant, neonate examination. And the art and science of bedside clinical medicine, this is very, very important. You present the cases regularly, either to the faculty or to the seniors. This is what Sunil Abraham has clearly told you. Go on presenting the cases. Even if the faculty doesn't conduct the bedside classes, if they don't take the bedside classes, if they don't come forward, you yourself take the initiative, have a dashing approach, have a dynamic and proactive, and you yourself present the cases to your colleagues or seniors. We learn through practice. That is the important thing. A well-known proverb, Chinese proverb says that if I hear, I forget. If I see, I remember. If I do, I know. So practice, practice, practice. That's very important. Go on presenting the cases from day one itself. Follow a sequential attempt for arriving at a diagnosis. Etiological diagnosis is a clinical guess, possibly only after a logical derivation of the anatomical and pathological diagnosis. It is important to localize the disease to a microanatomical site. Make a functional diagnosis. And of all, one more important thing is you must be thorough. You must have thorough knowledge about when to refer the patient. Because when to refer the patient is not being given with a family medicine concept. Even the examiners also ask this question. As a family physician, how will you manage this case? When will you refer the case to a specialist or the experts? You should have a you should have an understanding clearly, and without any hesitation, you should be able to clearly answer these questions. And Reichel textbook has given very nice. Suppose in case of musculoskeletal disorders or rheumatic diseases, when to refer, he has given a big para. Suppose it is septic arthritis, if there is any rupture in the muscle or tendon, or when any immunosuppressive drugs are needed. There are so many conditions where you have to refer the case. You should have an understanding because every case in the practical final year examinations, the examiners will definitely ask how you manage the case as a family physician and when you will refer to this. And the treatment approach in primary care, this is, they're very particular. You should know this. And here also, again, you utilize the fact practicals, have an idea about ASCII also. Because all of a sudden, the national board may change the pattern of the exam and they may introduce ASCII. Last time, 2017, I think so, I suppose, they have introduced the ASCII type of pattern type examination. So we all rallied our faculty and we conducted several classes. So parallel, you just know about the ASCII, its pattern and various type of questions. So final exams, and you should know that the examiner may intervene at any level and ask you differentials, provisional diagnosis, eliciting of the signs, investigations, drug profiles, treatment, summary, and final diagnosis. At any level, he may ask all of a sudden, you summarize the case. You summarize the findings. Only when you practice, only you have a good practice, you can answer very confidently. And that is why I'm stressing upon regular presentation of the cases, because the examiner may intervene at any level and ask any of these aspects. And moreover, you know the definitions. And the examiners are very particular. Suppose in medicine, you always follow Hutchinson's critical methods. Suppose example is apex beat. that it is the lower and outermost point of definite cardiac pulsation. Don't just miss any one of this. If you see a simple, the lower and outermost point of cardiac pulsation, where is the definite? Every word has a meaning. Just like tremors, myoclonus, tone, power. There are so many words which all you should be familiar with. You should know the definitions. They will ask the definitions. And be thorough with the basics. And you should know how to write the case sheets also. And actually, I thought of incorporating one model, one pro forma of the case sheet, but due to the time given to me is only 20 minutes. So I'm not dealing with it, dealing with this pro forma. So final shot, and one thing is final diagnosis should be concise yet comprehensive. Suppose in a case of MR, you tell in detail that it's a case of severe mitral regurgitation of rheumatic etiology with pulmonary hypertension in sinus rhythm, not in failure, no signs of infected endocarditis, functional class 2. This is how you should tell the final diagnosis. So just the aspect that I have told previously, you should thorough with all these things. You localize the lesion. Suppose this is a respiratory system, airways, it has mainly 4 components: airways, alveoli, interstitium, and pleura. If you have chest pain, you suspect that pleura is involved. So each part will definitely present with different characteristics. So don't jump to etiology first. First, you may make an anatomical diagnosis, followed by pathological. Then only you can derive the etiology and the functional diagnosis. Similarly, I am given one more. In the practical examination, they will conduct the tray viva also, where ECGs are being given, ECG, X-ray, and they may ask you lab investigations, and they may give you one instrument and what are its uses, how it is being used, what is indications. Similarly, essential drugs like noradrenaline, NTG, atropine, dopamine, dobutamine. So all the essential drugs, you should be thorough with the essential drugs. Sometimes they will ask you, you pick up one drug and tell me the adverse effects of this drug. What are the indications like that? So, and if you ask, they will give you ECG, and they may ask you just read the ECG. Then you have to tell in clearly it is in sinus rhythm or not. What is the QRS interval? What is the QT interval? Any STT changes? All these things you have to methodically you have to do. Otherwise, sometimes they will ask just simply you diagnose, give the diagnosis. If the time is short, simply they won't ask you read the ECG or read the X-ray. Simply they will ask give you the diagnosis. Then you have to tell that it is a case of atrial fibrillation. The diagnosis is atrial fibrillation or BT or VF, like that. So it is, we used to call it, during our time, we call as a tray viva. In the midst of the morning exam itself, you have to appear for the tray viva, because it's a big tray. In the tray, there are all the ECGs, X-rays, and lab investigation cards, instruments, essential drugs will be there. They will ask you. And afterwards, during our time, in 2007-8, we used to appear for one long case and 5 short cases. And that is in the morning from 8 to 1. We are asked to present almost 6 cases, 1 long and 5 short cases. Now the pattern has changed. There is no long and there is no short, and there are 4 questions. And at that time, we were not having any surgery case. Now they are putting medicine cases, surgery, OBG, and pediatrics. And in the afternoon viva, we have family medicine viva. All the morning examiners, they will sit and they will ask the questions. And viva by SPM examiner it is also being given. Actually, during our time, the practicals, there are altogether 300 marks, 200 marks for the cases. Long case 75 marks, 25 marks for each short case. That comes to 200. And in the afternoon, it is 100 marks for viva. And the family medicine viva, 50 marks were allotted, and the SPM viva is again 50 marks. So in the viva, altogether, it is 1/3 of the marks is being given through viva. So you have an idea about the latest marks distribution, and you have to aggregate, you have to pass out of 300. If you get 150 marks, they will pass you. And the next is logbook. And the logbook, you maintain the logbook. Sometimes they may ask you, they may not ask you. Sometimes the national board itself, they insist that you have to produce the logbook at the time of the examination. And even the DNB says something at the ground level, at the institution where you appear the exams, they may not ask you. Sometimes some examiners, they will ask you to show that, and from the logbook itself, they'll ask questions. So you have an idea about the marks distribution. These reference books, you please read. And Hutchinson's Clinical Medicine, MacLeod's Clinical Examinations, Chamberlain's Bedside Clinical Medicine by Kundu, 2 volumes, Essentials of Bedside Cardiology, Jules Constant, Bickerstaff's Neurological Examination, Friends Index of Differential Diagnosis, 2 parts, 100 plus clinical cases in pediatrics, and say similarly in OBGYN also there is books, Lessons from the Grand Rounds by V.K. Amdekar and others, a manual on clinical surgery by Das, and an introduction to electrocardiography by Leo Shamrath. I think I covered in this brief talk all the aspects of both the theory and practical examinations. Be confident and prepare very well from the day one. The practice is very important. As Reshma has told you, we should learn from the patients. Every day's activity, be proactive, involve yourselves, and just like don't blame your faculty, or take the initiative and have first of all, you develop a passion towards family medicine. That's very, very important. If you are passionate, you will achieve everything. All the best, my dear PGs. Become bright colors. Thank you very much for giving me the national Spice Root national team for giving me for this opportunity. Thank you very much. All the best.
Welcome, sir. Thank you, sir. And now we'll be moving to our next session by Dr. Srividya. She is a Royal College examiner for South Asia region for MRCGP International. She did her MRCGP, CCT, and DRCOT from UK. After learning there, she came back to India for giving her experience to our young students of family medicine. She did her DFID from CMC, and she has over 15 years of experience in this profession. Welcome, ma'am. We would like to hear your wise words.
Hi, Gunjan. Thank you so much for inviting me for this very interesting session. And I know we are coming towards the later part of the day, and with so many things, a lot of information shared. I'm not going to take a lot of time, but this is one of those important topics which a lot of people are running away from, and I'm sure the previous PGs and the PGs who are currently there will also agree to it. And I wanted to briefly talk about how to start preparing for your thesis and how important it is in the first few months when you start doing it. And I understand that in undergraduate years, we are not used to preparing for the thesis. And as you enter the postgraduate year, you will realize that there are a lot of things on plate. And we wanted to simplify this process as easy as possible and keep it as a very simple way to get things done on a regular basis. I'm happy to say that today there are few topics which I'm going to briefly touch upon, why it is important to do it, how to select a topic, and how to write a protocol, and what needs to be sent to NBE. And I'm sure with your seniors, you would have understood that how the process works and what needs to be done in this. So these are the important things to remember in terms of your thesis thing. I just wanted to see if people can raise hands. How many of you have started thinking about what to do in terms of what topic? Have you started the thought process on what topic to do? Can someone, whoever is done, could you raise your hands? Yes, I could see one. That's great. All right. So I'm sure the discussion is happening in your department. So these are the few deadlines to remember. One is to sit with your team, sit with your faculty, discuss about what are the topics which could be done as a thesis. And also the important part is we all have to remember one thing. We are all doing family medicine. So we should focus on primary care based topics because that is key part of our work. And as much as possible, try to avoid hospital based topics. Of course, we are all doing hospital rotation, but try to choose a topic. Let's say, for example, the common things which we generally see, right? So diabetes is something which we generally see. There are certain things about antibiotic usage. That is something we could look into. There are certain things about few common things, right? The treatment of antibiotics for upper respiratory tract infection. So there are a lot of things which we could work on in terms of what topic to choose and how do we choose about it. And first step is to discuss with your faculty, discuss with your team members, and you also have to start thinking about what topic will help me to choose and what would be my interest, right? So that is something. But the irony is we'll have to submit the initial protocol within first 3 months of joining. So a lot of residents keep telling, ma'am, by the time I understand what family medicine is, by the time I start realizing how my department works, what needs to be done, 3 months is already gone. But we have to follow the deadlines. We are in discussion with the board. We can talk about it. Maybe things might change a little later, but currently you'll have to submit the protocol in 3 months. You'll have to present it in your scientific committee, in your respective hospital, get it approved, send it to NBE, and then another, I have written something on progress report, right? So a lot of people I keep seeing that, especially during the FAT exam when we go end of first year, end of second year, they would have sent the protocol well on time, and everybody sits in the last minute to sit and finish the final collection of the material, collection of the information, and then putting the Excel sheet, and then a lot of time is wasted in the later part of your training, which should be actually dedicated to your learning part, because that's when your theory and the practical exam is there. So if someone asks me when I should get it done, I would generally tell them, choose your topic within first year, try to finish your sample collection. By middle of second year, start writing your thesis. And by end of second year, you should complete your thesis. Don't keep it till your final year, because that is just going to take a lot of your time and effort, and a lot of anxiety builds up around it. So the sooner you complete it, better it is. By thesis and by what is quality control. As you could see, NBE has a special review panel. We as a faculty get it on a regular basis to evaluate how good the protocol has been sent. And some are accepted, some are rejected. So this is how we get the letter. You will probably get a letter from the board depending upon whether your protocol is accepted or not. What is research? Everybody knows. It's finding answers to our questions. We all have a very thought-provoking mindset. We want to learn. We want to find why, how we can make it better. So research is a tool which actually helps. And PICU questions, I'm sure all of you know what type of patient or what condition we are going to look into, what intervention we are going to do. Is there a comparative study? What is the outcome, type of the study or duration of the study? This is an important tool, which I think for any evidence-based checking, this PICU search is quite important, and we use it in our research protocol as well. Idea generation is very important. So I'm just going to briefly get one simple example on how we can work on our thought process, right? Let's say a 5-year-old girl is coming, and Millie is 5-year-old. She's not speaking much, we do see that by 3, majority of the children are able to communicate, understand, respond very well, but Millie is not able to. She makes some sounds, but the parents feel that's okay, it's fine. But then we realize that there is some amount of moderate hearing impairment, and we look at different things, what could help Millie in this process. And then we found out that there are multiple factors involved, and then if there is hearing aid or cochlear implant, which will help the child, what would be the best option? How do we differentiate between the two? What is the distribution? What is the belief among the people? There are a lot of thought processes are involved. So if you look at it, there are so many questions can come into our head. And when we start looking at it, first and foremost, how common it is, who are at risk, and where can we find information? What is the parents' belief on that? So a lot of parameters are involved when we start thinking about idea. And research question, hypothesis, objective. So when we look at the research question, especially for this case, we can think about, is there a difference in between hearing and cochlear implant? That's a research question. Our objective is to compare the effectiveness of hearing aid and cochlear implant in child under 5 with moderate hearing impairment. See, the idea is we have 2 parameters here. Which works better? Which is a better option? How do we objectively look into it? What are the associated factors involved? So this is just an example I'm giving. So you don't have to do the same one. This is just an example to think about how we can build up our questions and what can be done in forming our research questions. And always ensure that the objective has to be measurable. So we had a scenario where we wanted to know that, I'm sure you must have all seen diabetic patient, you must have all seen thyroid patient, you must have all seen blood pressure, high blood pressure and things like that on a regular basis. How many of us know how common it is to have hypothyroid in our diabetics? Have we looked into it? Is there a way we can figure out what is important? And what is the prevalence of microvascular complications in our diabetic? So these are the questions which can help us to think more about our research topic and how we can work on it. A lot of my PGs have worked on these kind of questions which are more practical, which is more interesting to do because it is clinical based questions, and that will help us to concentrate more. And I'm happy to say that a lot of my residents have published papers on it. And just researchers, the thesis is not just for your completion. If you're working on your academic platform, this would be a great thing where you can publish your thesis. So that is something we should work on as well. So review of literature, always look at last 10 years I've written, last 5 years is more valuable, up to 10 years is fine. These are the common 2 platforms where we can look for our literature review, what things to look in each article. That is very, very important. When and where it was done, how much was your sample size, how did they do it, what they found out, is there any conflict of interest? These are the important things we should remember to understand the validity of the article. After looking into article, then check about, is it answering my question? Is there any lacuna? Is there a place where there is something missing? So that will tell us whether is our study really useful or not. And when you guys have to send the protocol in the first 3 months, ensure the protocol is sent, consent is sent, scientific committee approval letter is sent, ethics committee approval letter is sent. These 4 are the key parts which needs to go in when you submit your initial protocol to NBE. There are a lot of times people miss sending the approval letter and then it comes back again and it delays the process. So do not waste time on these things. And these are simple checklists to remember and get it done. So this is a protocol structure. I'm going to go through about it a little later. General guidelines, all the candidates should strictly adhere to the protocol template. Use the same font size throughout. Don't keep changing. It should be either Times Roman or Arial font. And the font should not be bold or in italics. So that is something which is very important for the template. Mention your guide with designation, your full name and your DNB number. So a lot of times when we see the thing from a national board, they had missed few small things, and that again delays the process because candidates has not written the number, they have not written the designation, all those things are there. And references should be addressed with superscript. I'm sure you all know how to do that. And introduction and justification. This is a key part of your protocol or your thesis part, where you will have to find out answer for these questions. And then if you're able to get answer for these questions, then it means that your study is a very, very useful and a valuable study, and you will get enough data on how to work on the study. All the lines, when we are looking from the other article, right, that is for reference. We cannot cut and paste it. It has to be paraphrased. So please remember, you have to paraphrase it. You can quote, you can definitely quote those articles. That is very important, but you cannot just cut and paste it. You will have to use your own words, your own terminology, and your own justification on what did you understand from these articles and how you are bringing it up. So when, let's say, for example, we looked at the prevalence of microvascular complications in type 2 diabetic, there are lots and lots of studies done which will help us to understand the intensity of the problem and the gravity of the problem. For our role, when you're putting it in your thesis paper, in your protocol, in your review of literature, is you pick that article, you understand what is there, and then put it back. But paraphrase on your own words, not cut and paste. Yeah, this is very, very important. One takeaway message which I want all of you to do is please paraphrase, don't cut and paste. Material size, I'm sure the statistician in your department, in your hospital, will be able to help you with how to calculate the sample size and all those nitty-gritty of it. We are not statistician. We can get help from them, and they should be able to help us with the numbers. Consent, informed consent is a key part for when you're doing your sample collection. It has to be in patient's words. Local language translation, we practice in Karnataka, so we always have in my place, we always have a Kannada translation for patients understanding who are not able to understand English. So it's not fair when we have an English consent form and ask people who are not able to read to do it. So please bear in mind, it has a local language translation. And this is a DNB current guidelines on thesis. What are the key parts they request or they look for? One is guidelines for writing. It should be very brief and clear on the title name, introduction, what is the purpose of your study, what is the current understanding of this subject, and how you want to go about it. Review of literature should be very relevant, complete, and current, which means the latest article should be put on the top and the older article to be later part of your study. The latest article, better it is, but up to 10 years, you can still use it. Materials, again, these are all statistical part. You will have to write it, of course. Observations, what was the thing? Again, make sure that there is minimum 6 to 8 tables, 6 to 8 flow charts, and all those things which would help people to understand, especially the graphs and the diagrams and the charts. So that is more self-explanatory, and that will help people to understand better. Discussion should be in your own words, and summary and conclusion in your own words. What did you understand with your observation? What was your finding, and how did you come up with how you can implement in your practice? So these are the things which the board is looking for, so that as a practicing clinician, we all should be doing evidence-based practice. We should ensure that we are up to date with our clinical practice, and these kind of things guide us or help us in this process. And as I mentioned earlier, try to select only primary care-based topic as much as possible. And we are all there. Any doubt, ask through Spice Route. We are there in AFPI group. You can talk to us. We have been a faculty for family medicine residents for a while. Myself, Dr. Rashmi, Dr. Srinivas, quite a few of us, and people who are part of Spice Route have been helping residents. And as I mentioned earlier, don't take it as a burden. Thesis is one of those important things which will help you in understanding on how to do evidence-based practice, as well as if you're planning for your academic role in your future years, publishing this thesis is a great thing to do. We have a great, amazing journal of family medicine and primary care, which Dr. Raman and team are doing a great job in publishing primary care-based study. And these theses which you are working on can be a good study as well that can be published. And as I mentioned earlier, a lot of my residents from Baptist have done it, and we would love to see many more things coming up. And I think I will leave the place to Dr. Digvijay to take over. Thank you so much for inviting me. Any queries, please post it or send it in WhatsApp. We are happy to address. Thank you.
Welcome, ma'am. And now we'll be moving towards our next session, which is experience by recently passed out PG students. I would like to invite Dr. Hari from Tamil Nadu. And if possible, just finish your experience in 2 minutes, okay? Dr. Hari, can you hear me?
Hello.
Yeah.
Can you hear me?
Yeah, we all can hear you. Please start.
Yeah, we can hear you.
Okay, ma'am. Since we are in the past 9:30, I will just crisply tell my experience. I have joined family medicine in Meenakshi Mission Hospital, Madurai by 2019 and passed out last June 2022. And to my experience, I would like to give some points for upcoming PGs, like prepare for examination all in group along with your colleagues. And also I request all the PGs to have other department PGs like pediatrics, OG and general surgery PGs to collaborate and prepare for examination, so that it will be very easy to carry out our anxiety out. And for practical examination, frequent case presentation will be very helpful. And other all topics are briefly explained by all our faculties now. And that's it. If there is anything more we should discuss, maybe we can have a elaborate session to discuss all our experience separately in this different session. Thank you.
So now we have Dr. Anuna. She's from Kerala. We would love to hear your experience. You are not, please unmute yourself.
Yes, sorry. Good evening all, and congratulations to all my fellow juniors. I am Dr. Anuna Vinod. I had completed my post-graduation from Lutz Hospital, Kochi 5 months back. I'm currently working as a senior resident in family medicine in PGIMR, Chandigarh, and I'm posted in a rural center where I'm managing independent OPD. The care I'm able to give the patients here is undoubtedly because of my training during my PG days. So with respect to my experience about my postgraduate days, I'm a person who wanted to take a family medicine right from my UG days. And also I happened to do PG from an institute which had a proper DMP curriculum and an excellent mentorship. So it was easy for me to navigate through the process. That might not be the case with many here. So I think the first step is basically getting to know your specialty. There's no better way than this orientation session for that. And I'm not going to stress on any academics, how important that are. We know that, acquiring knowledge to a large extent will happen in the process of the training itself. A little effort during the daily posting will go a long way. And I'd like to just share 4 specific points, which I feel are worth mentioning, because that has helped me deal with the patients here. First, about the learning from different specialty posting during our training, we all know that it is not easy. Because we're in the other department, it's important that we ascertain our exact need. So firstly, we should have a clear idea about what we intend to learn from that subspecialty. And also we should be able to vocalize that when in need. And most importantly, we should be confident about our specialty. We should always remember that we are doing a specialty training just like how their PGs are, just that you should never assess yourself with their yardstick. So accept the fact that they are doing a deep vertical learning, but we are doing a relatively horizontal vast learning. So as Dr. Rishmi rightly mentioned, we should make lemonade out of the lemons. So feel free to ask doubts and utilize every learning opportunity you get while you are in a subspecialty. The fact is that looking back, we really don't regret for the extra duties we have taken because there's always a learning involved. Secondly, I'd like to emphasize the importance of handling OP patients alone. There are hospitals, I gather, where there is no OP exposure involved. Mostly they're at the ward ICU and all. So, but sitting in the OP, seeing the follow-up patients and learning the ways in which the consultants communicate and handle, especially the tough patients and the bystanders, these are going to come very handy when we deal our own OP. And the most important point being learn the art of talking to patients, the fine balance, try to see, observe and learn. Basically the empathy to look out for the patients and the diplomatic nature that we should have to look out for ourselves. These two should be very important. And as I said, 4 points, the fourth point being, be active participants in the clinical sessions conducted in the institute. It's funny how during the exams, we wish we had presented more sessions because trust me, those are the only topics which are going to stay in your head at that last moment. And make sure that you participate in every conference, clinical presentation, journal club and meetings as much as possible. AFPI and SpiceRoute will give you a lot of opportunities for that because that's how you update yourself, not just professionally, but also at a personal level. And lastly, please never be hard on yourself when you make mistakes. Accept and try to learn from them. As a footnote, there are days when patients bring in their family members to my OPD to make sure that I have a look at them. Just sometimes even to just clear doubts or explain to them about the disease or the ailment they have. Now, I think that is exactly the point after stepping out from a PG institute where we become an actual family physician. Well, I'm a happy one at that right now. Thank you.
That's so sweet of you. And now we have our third PG, Dr. Begum. We would love to hear your experience.
Hi all, I'm Dr. Begum.
Your voice is breaking. Yes.
Good evening all. So I'm Begum from Kerala. I recently passed out from Rangadhari Memorial Hospital, Bangalore. Now working as a family physician at Malappuram, Kerala. So all the points, all the PGs and all the faculty told. So we have to some points. Always good your seat and join because as a PG actually prepared for the exam throughout the years. But even after preparing throughout the 3 years, finally I felt
We can't hear you. Dr. Begum, are you still there?
I think she's logged out.
Yeah, some network issue. So no problem.
Maybe someone else, maybe Digvijay can give us his experience after passing out DNB.
Sure. Sir, we would like to hear some words from you. You are still mute, sir.
Yeah. So thank you, Dr. Gunjan. Myself, I am Dr. Digvijay. So I was about to give the vote of thanks, but I will just speak now. So I am the SpiceRoute National PG Coordinator. So any of you residents, ever you have any queries or any requests, any topic on which you want us to do a seminar on, you can always reach out to me or any of our SpiceRoute team. And of course, we also have SpiceRoute state PG coordinators. You can reach out to them as well. So this is the first time we are organizing something like this on a national level. And when I was in PG, I never had this sort of exposure, this sort of experience. And so I would say that each one of you should use this opportunity. And we will be having lots of academic exposures, lots of webinars, lots of meets, and I would be looking forward to interacting with you all. So coming to my experience, when I was in PG, in my state, there are not very many hospitals where they teach family medicine. So like in the South. So this is, we are still struggling on that part in this city. But so when I started in my hospital, I started. So when I started, I joined, and me and a fellow candidate was there. So only 2 of us were there in the family medicine branch at that time. And ultimately, that candidate he resigned from the post. So in my full residency, only me was there in that whole branch in that hospital. But I received a lot of support from all other branches, all other fellow DNBs who were there in other branches like medicine, surgery. And I never felt that family medicine was a below par branch or something like that. And all my teachers, they were supportive and they used to teach. So I never had that feeling that I have joined something which is not at par with general medicine. So this has helped me in building my confidence as well. And I used to learn a lot from the rounds and from the bedside teaching, because there was a shortage of classes which were going on in my hospital at that time. So we had to learn a lot from the bedside teaching, the classes, the rounds which the teachers used to do. And I learned a lot by studying myself, and that ultimately helped me in passing DNB, which at that time we thought that people won't be passing in the first time and they may have to try again and again, but that didn't happen. So people who were there with me, they were also surprised that yes, people can pass DNB the first time, that is possible. So this is coming up and people are studying and they are succeeding the first time itself. So I think you should all study hard and try to enjoy family medicine. I still feel that the enjoyment is the most interesting thing, because in family medicine, in my family practice, I see a lot of interesting cases and I am never bored. So that is an important thing. And if any help, anything which you want us to do, we can always help you. And I would like to thank our eminent speakers today, Dr. Raman, Dr. Vandana, Dr. Mohan, Dr. Sunil, Dr. Srinivas, Dr. Srividya, and of course our very own Spice Route National Council members, Dr. Jyotika and Dr. Kailas. Dr. Serin, our national chair, got stuck in traffic, and I don't know whether we will be hearing from him today. And I would like to tell you that please make this bond even stronger. You have joined a beautiful family, a large family of family practitioners, and you can strengthen this bond even further by becoming a member of AFPI, and indirectly you will become a member of Spice Route. So I will tell you all to work hard, and I look forward to interacting with you all. Dr. Gunjan?
I guess Dr. Saran cannot join me. So while we are closing in, there is one thing I would like to tell all the new residents who have joined in. One of the students had asked me, he was apprehensive about the branch and the institute he was getting. So I told him, think of yourself as the movie Santara. The budget and the regional cinema would not define the scale of the movie. The content should be nice. So as a student, your learning, your sincerity, and you as a clinician will define how far you go, not the department's name and the institute's name. So that is the take-home message all the students should take, and how actively you get involved with the AFPI will definitely make a difference.
Yes, well said, Gunjan.
We
Okay,
can
so I think
close,
we'll
I
call
guess,
it a day. Yes,
Mhm.
and we can all meet on WhatsApp. We all are reachable. Thank you, everyone, and good night.
Good night, everybody. Thank you for joining me today.
Thank you.